Welcome. In this clinical review, we're going to break down the causes of hypothyroidism. We'll be focusing on the high-yield info you need for both your clinical practice and, of course, for exam prep.
This educational content is by Dr. Mohammed Al-Nagi Mohammed.
So, here's our game plan. We'll start with a quick clinical overview, then dive deep into the number one primary cause, Hashimoto's. After that, we'll cover some other primary causes, explain secondary hypothyroidism, and look at some key clinical associations. We'll wrap it all up with a high-yield review specifically for those prepping for exams like the MRCGP AKT.
Okay, let's get started. First up, we need to get a handle on the clinical landscape of hypothyroidism. Who gets it and the main ways we classify it. So, just how common is this? Well, it's pretty significant. In the UK, hypothyroidism affects about 1 to 2% of women. That makes it one of the more common endocrine issues you're definitely going to see in general practice.
And there is a massive gender gap here. It is way, way more common in females. We're talking 5 to 10 times more common than in males. That's a huge demographic clue right there when you're thinking about a diagnosis.
So, when we classify this, the most crucial question is, where is the problem? Is it a primary issue, meaning the thyroid gland itself has failed, or is it secondary, which is much rarer, where the problem is actually with the control system, the pituitary gland, which isn't sending out the right signals?
Now let's really zoom in on the single biggest cause of primary hypothyroidism, and that is Hashimoto's thyroiditis.
So what is Hashimoto's? Well, simply put, it's an autoimmune disease. Your own body's autoantibodies, specifically things like antithyroid peroxidase antibodies, are attacking and slowly destroying your thyroid tissue. Over time, that leads to a decline in hormone production.
There are a few key features here that are just classic exam fodder. Not only is Hashimoto's the number one cause of hypothyroidism, but it also loves to hang out with other autoimmune conditions, like type 1 diabetes, Addison's, and pernicious anemia. And here's a great clinical pearl. Sometimes early on, it can actually cause a temporary hyperthyroid state. We'll talk more about that in a bit. Okay, so while Hashimoto's definitely steals the spotlight, it's not the only reason for primary hypothyroidism. Let's take a look at some other important causes. Your differential for primary hypothyroidism has to include other inflammatory conditions, like subacute or renal thyroiditis. And don't forget iatrogenic causes, things we do to patients, like after a thyroidectomy or radioiodine therapy. And of course, on a global scale, simple dietary iodine deficiency is still a major cause. You absolutely have to do a thorough medication review. There are some key drugs notorious for causing hypothyroidism. Think about antithyroid meds like carbimazole, the mood stabilizer Lithior, and the antiarrhythmic imidazole. These are super high yield for exams and just crucial to spot in your daily practice. This brings us to a really interesting clinical puzzle. Can a condition that's all about low thyroid hormone actually show up with symptoms of high thyroid hormone?
And the answer is a resounding yes. In that early acute inflammatory phase of something like Hashimoto's, the destruction of the thyroid follicles causes a huge dump of pre-made hormone right into the bloodstream. This creates a temporary state of thyrotoxicosis before the gland eventually burns out and fails. All right, let's take a quick but important detour into secondary hypothyroidism. Remember, this is a problem with the control system, not the gland itself. Secondary hypothyroidism is a pretty rare diagnosis, and it all comes down to pituitary failure. The thyroid gland itself is perfectly fine and capable, but it's just not getting the memo. It's not getting enough stimulation because the pituitary isn't secreting enough thyroid-stimulating hormone, or TSH. Next up, let's talk about some key clinical associations. Spotting these comorbidities is just essential for good, proactive screening and managing the whole patient. You'll see a higher rate of hyperthyroidism in patients with Down syndrome and Turner syndrome. There's also a really strong link with celiac disease, which makes sense, as they probably share some of that underlying autoimmune pathophysiology.
Okay, we've covered a lot of ground. Let's boil it all down into the most critical, high-yield points you need to take away for your exams and your practice.
So here are your key takeaways. Number 1, Hashimoto's is the top cause of primary hypothyroidism. Easy. Number 2, always screen for other autoimmune diseases, especially something like pernicious anemia. Number 3, remember those key drugs, lithium and amiodarone. And finally, number 4, don't forget that it can present with that weird initial phase of thyrotoxicosis.
So let's end with a quick clinical scenario to put it all together. You have a patient with a known history of pernicious anemia who now comes in complaining of new fatigue and weight gain. Knowing what we know about the strong links between autoimmune conditions, what should be shooting to the top of your differential diagnosis?